Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, I'm joined by Dr. Simon Cos, Chief Clinical Officer for ANZ at Microsoft, Georgia James, Director for VicKey Statewide CRM at Austin Health, and Alan Pritchard, Director, EMR and ICT Services, also at Austin Health. G'day, team. How are we going?
Good.
Thank you.
Thank you.
It's great to have you all on the show. We've spoken at various levels across events and some episodes and summits and bits and pieces, but great to bring you all into this conversation today. I love these episodes where we can talk about the potential of technology, but not just what technology can do, but what it's really doing right now and where we're heading in different health systems around Australia and the world too. But for those unfamiliar, maybe we get to know you all a little bit more. I might start with Georgia, if you can introduce yourself, tell us who you are and what you do, and we'll go from there.
Great, thanks. So my name's Georgia James. I am the Director of the VicKey Statewide CRM, as you said. So I work really closely with Alan and the Austin IT team to roll out the CRM, the Microsoft Dynamics-based CRM across statewide services in Victoria.
Love it. Thank you. And Alan, only recently we spoke for a couple of minutes at Digital Health Festival, but great to have a longer form conversation with you. For those that might have missed that, tell us who you are and what you do.
Thanks, Peter. Good to see you again. And thanks for having me along. I am Alan Pritchard. I'm the IT Director at Austin Health. So I am responsible for nearly all of our systems. I'm not responsible for finance and HR systems. And I am also the Technical Director for the VicKey statewide rollout of the Austin Health CRM, effectively.
Got it. You at least you got all the fun ones, and then let someone else deal with the HR and finance. Important nonetheless, though. I'm allowed to say those things. Simon, great to see you here. I think we were talking just at HIC a couple of weeks ago that we've done a bunch of things and spoken many times in the ecosystem, but I'm not sure we've done a full long-form episode before, so great to have you here.
First recording. It's great to be here, Pete. Thank you for the invitation and great to be here supporting the Austin. So I'm Dr. Simon Cos. I am the Health Director for Microsoft across Asia, and I've got a background in emergency medicine where I practiced here in Australia.
Love it. I think a lot of this conversation will frame around the statewide CRM to learn a bit more about what that is and how that's been rolled out at Austin. Maybe, Georgia, if you can give some context and frame it up on that and why it exists, and we'll go from there.
Yeah, so it actually all came out of the surgical reform work. I think Alan and I started this journey about 3 years ago. We first pitched to the Department of Health. And it was really an acknowledgement that great things were happening at Austin Health with the CRM and that kind of patient communication and being able to automate a lot of that. And then Alan and I came together and realized that there were things that were required of health services, like auditing patients who are on surgical wait lists, that could be made a lot easier rather than manually calling the about 80,000 patients across the state at the time who had been waiting too long for care. And so we kind of came up with this idea that actually instead of just building something for Austin, could we build something for the Northeast Metro Health Service Partnership, which at the time was 6 health services across that kind of region. So Austin, Eastern, Mercy Women's, Northern, the Ioneer and St. Vincent's Hospital, Melbourne. And the department very gratefully kind of went on that journey with us and believed in us and the ability to create, as I think Simon's kind of talked about previously, that integrated journey across multiple health services and bringing together data. And so we did surgical audit to start with, and we also built a tool called Endoscopy on the Park, which is about inter-hospital transfers, so moving patients from Austin, Northern and Eastern to access endoscopies faster at newly created services in St. Vincent's, and then being able to hand them back. And so kind of not losing patients and not relying on lots and lots of manual Excel spreadsheets. So we did that for about 18 months very successfully. And then December 2023, the department actually commissioned us to expand that on a statewide basis. So we've been on that kind of expansion journey for about 18 months now. We've got almost full coverage of metropolitan Melbourne. So we've got 2 services left to bring on, one of which is coming on next month. And then we've started bringing in regional services as well. So we've got Ballarat and Bendigo, and then we'll be bringing in the Hume, the Southwest, and the Gippslands regions next year.
Got it. And Alan, I understand, a part of it, or something, a concept that many in the system might be aware of, or at least heard of, is electronic referral management, or ERMs, and a system to manage that. And what I understand, that's all part of this broader rollout. Tell me a little bit more about what the purpose of that is and how it kind of works.
When we started this journey that I suppose landed on us building solutions on the Microsoft Dynamics CRM, it was because one of our business analysts, David, had gone and spoken to lots of people and realized that there were many problems across the health service that people articulated in different ways, and they all fundamentally collapse down into 2 key concepts, I would say. The first one is managing processes that don't naturally home within any one of our core systems. And the other is communicating digitally with patients. So everything we've done really from then on is around either one of or both of those functions. The reason managing referrals was one of the early targets that we looked at was because that is a really difficult process in a health service if you don't have a good system to manage the process. So referrals come in by a variety of means, and the process then touches many people. First group needs to decide whether this thing is actually a referral or whether it's some other sort of document. The next group then, if it is a referral, needs to allocate that referral into the system, to the PAS, and register the patient if it's a new patient. Then it gets passed on to a doctor to triage the referral, and then it goes back to one of the admin teams to book them according to the doctor's triage. In a non-digital world, that is literally pieces of paper being couriered around a very large health service, and it takes a long time. It is fraught with delays and issues, and it's really not an efficient way to manage anything. So our first attempt was with the CRM was to digitize that process, which we've done extraordinarily effectively, I would say. So now it doesn't actually matter how the referral comes into us. We don't care if it's faxed or emailed in or whether it comes in electronically. Everything goes into the same process and gets managed through a standard process, which ensures we don't ever lose any referrals. It ensures that everything gets processed the same way. And most importantly, it ensures that everything happens much more quickly, because in the old paper-based system, it could take several days for a referral to be processed and get into the hands of a doctor to triage it. And it could take several more days after triaging for it to get back to the admin people to book it. Now we can literally have referrals on the desk of a doctor within hours of them being received at the health service and immediately processed and booked. So huge efficiencies, much better for the environment. We're not printing things and sending them around the place. Cost savings. It's good outcome all around.
Well, look, I mean, Simon, I think about, and I'm sure someone listening to this episode can either relate personally or someone they know for perhaps an interaction with their health system. And then if you're unfamiliar with, you go to your GP and you need to go see someone else, you might get a letter, but half the time sometimes could be spent just going, well, where's your letter? Or is it, there's a lot of things that a patient has to kind of take an additional cognitive load of that probably isn't really their problem. Like it's and we kind of, in that non-digital world that Alan kind of alluded to, that for something that is important but also probably shouldn't be that important for a patient, I imagine you've seen in other parts of a health system that this is a pain point that is felt, everywhere.
Yeah, absolutely. These systems weren't designed for patients. If we go back, you think about organisation managing this highly sensitive, confidential information that then somehow needs to be secured and shared. It starts with organisations and record keeping. So in a hospital context, that's a paper medical record that you then go ahead and digitise. When you look at the systems that we have, the exemplar EMRs that are common in Australia come out of the US system, and the US system doesn't have referral management. You can go straight to specialists directly. So there's always going to be a gap. The electronic medical records do that one thing very well. They manage the records of the patient within that context. And then out in primary care, the systems that GPs are using also manage the records within that organisation. What we're talking about now is who takes responsibility for the cross-organisational data flows, and what does that look like? If the systems you're using don't have that capability, you need to get it somehow. And as Georgia said, it starts with pieces of paper shuffling around, Excel spreadsheets, all the way up to where Alan is as receiving those referrals inbound. They're coming from a multitude of different organisations in different formats. Victoria would have to be the most varied of all the states, with lots of different systems across different health services. And it just means that you need to be flexible. And the solution as it stands today isn't something that can be frozen at a point in time and then used for the next 10, 15, 20 years. I think that local ability to customize, configure, layer in rules, evolve the reporting requirements, that's really important. So that's why a technology like low code, no code, self-configured, flexible industry grade platforms, that's going to be best suited to put the control and autonomy back to an organisation like Austin, or then bubble it up and manage it at a statewide level. And all of a sudden now, these orphan flows can be brought together and harmonised and done so securely. So who wins? Obviously, the organisations who need to manage all that intake and there's timeliness that Alan's called out. But at the end of the day, the patient now doesn't need to be the integrator. That data flow can follow them around their journey. And I think that's really important.
I think one of the other really exciting things is that we've actually got 2 other health services now using the electronic referral management system as well. So Mercy and the Royal Ionia both use it. And I think that bit where we've got multiple services on the same system means that when some of the really cool stuff that Alan's doing about bringing AI into referral management and referral triage, or being able to communicate back to patients, hey, we've received your referral, you've been waitlisted, this is how long we think you'll wait, and then you've been booked. That can all be done at scale as well. So rather than, we've got 76 health services, or soon to be probably about 70 with the kind of forthcoming amalgamations. But that's a lot of resource that has to go to being able to roll this out kind of at each individual service. Whereas I think that's one of the things that we're really excited about from a statewide approach is actually we can do some of this innovation at scale that maybe some of the other states have been able to do much more readily in the past.
That makes sense. And I want to come to some of the cool stuff that you mentioned that Alan was talking about. We'll come to that a bit later in the conversation. But just back to that point, it is a bit wild that we rely on the patient to be the integrator, as you say, Simon, or the mule between the courier between each interaction. And that just, when you've got, and the reason that someone is engaging with the health system isn't for fun. It's something that they're probably putting a lot of cognitive load on. So to add additional administration around, you can't see this person because they haven't got a letter, or we can't pay for this because it's over 12 months, like all these things. And I really like your point too, Georgia, that some may look at and go, oh, well, that would be a nice to have to give that engagement back to a patient to say, oh, we've received it as just a heads up. And if you can't do that in a scalable way, then that probably falls by the wayside. But like anything, in the absence of information, people will fill the gaps with their own assumptions, be it everything is fine and I'm ready and raring to go, or they'll assume if they haven't heard anything, then the thing has got lost in the system. So when you are being shuffled across different places, to know that there's that connectivity, we sometimes overlook something simple as that, especially in this world where we can do a lot of cool AI things. Keeping someone informed with the status and the progress of where they're at is super powerful, I think.
Just on that point, Pete, you raise the patients as the integrator. I think it's important to call out that the digital divide adversely affects the most vulnerable populations. So those people who have complex disease, cognitive impairment, disability, the people who are regionally and remote situated, people of non-English speaking backgrounds. So to the greatest extent possible, we can make a system that's equitable and provisions that for all. We take everyone forward rather than just supporting the people who can do well.
Hey, Georgia, I'm keen to unpack a little bit more the rollout side. Me being a bit of a doer in the health system from years past, it's all great to have the vision and the idea and what we're going to do, but then you've got to get this thing into the health systems, and that's really where the learnings occur and the changes happen. Walk me through how the implementation looked and some of the successes, the change management and things that are still kind of being chipped away at.
Yeah, so I think, so we, as part of the statewide rollout, we've been commissioned to develop 5, we call them modules. So the first is the surgical audit. Second is specialist clinics or outpatient audit. Then we've got a digital health questionnaire, the electronic referral management system, and then one that we're currently in the process of working through the development is into-hospital transfers. So basically the endoscopy on the park that I mentioned at the start, but at scale. So any transfer between health services being able to go through a single system and be documented and monitored and audited. So the change management process for that, as you can imagine, it's been big. But I think our mindset for Alan and I has always been, this is by health services for health services. So it's not kind of external companies coming in, but it's also not top down from the department of, we know what's better for you. So I think it has been that really genuine partnership and co-design process. So kind of for each module, how we've gone about doing that has been like really that kind of basic principle of get everybody in a room. So we bring together workshops with the right people from across health services to work through what is the shared understanding of the current problem with the process and what's that 80-20. So we know that, with 76 plus health services, everyone has developed their own bespoke processes for dealing with something as simple as, electronic referral management. Like, well, that's not simple actually, but dealing with something like electronic referral management, people create these systems based around what people they have available to them, but also kind of previous incidents. So safety incidents that we create, over 10, 20, 30 years, layers and layers of process and things that then create further problems. So we create more workarounds. So actually what we've had to do is bring people together and agree what's the common 80% of what you all do that we could build and we could support automation of, or at least kind of make it easier for you to do that bit. And then you can choose to, continue to do some of that other nuance around it with manual resources, or you could adapt your processes to fit this 80%. And actually the 80% becomes more like 95 or 100%. And that's actually what we've seen happen quite a bit with particularly referral management. There was a lot of quirky things that maybe were done at local health services or even within units within a health service. And they've actually, because I guess when you put everything into a digital process, it throws up where you're actually at and how things are working and where the gaps are, and allows you to build a better process. So it's not just digitizing the current process and all of its failings or foibles, but it's actually creating something better that really is fit for purpose for where we're at in healthcare delivery. And then we've got a wonderful team of change and adoption project managers that work really closely with health services to help them understand kind of what training is needed for staff, how they might embed it within their local processes, and then doing hypercare once we actually roll out the solution to make sure that that's all gone really smoothly. But I think for us, it's been that kind of very genuine co-design and respect that people who are doing these processes are the experts. Like, I'm certainly not an expert in how to do referral management, but I think what our team brings and what Alan and his team bring is just a different perspective, and helping people sort through what that system approach could look like.
I think that ties to what Simon mentioned before around, some of these low code, no code type tools that are available, or being able to build within the constraints and safety of a system. Because if I think about the reason why someone spins up a spreadsheet at work outside of the system isn't because they're trying to be an agitator and trying to be annoying. There's usually a reason for it. And it might be because the current system just won't let me do this, or it's such a long, I could just be doing it outside of here. And then that cascades more into things that are just annoying, and they create inefficiencies elsewhere. But then there's also safety issues if it's just easier for me to text this as opposed to send it through the system. And I think at that moment, at a project level, or if someone's doing the training site, what the worst thing that can happen is you kind of immediately jump to reprimand and say, well, you're doing the wrong thing. But the whole reason that came up in the first place was because they found a better way in their eyes to do it. So it could be that it's unclear how to use the system in the first place, and there actually is a better way. They've just done it for years and years that way. And so that's a learning process. Like, hey, great, look, other systems are doing it like this. And if they say no, because in reality, I click off over here, and then that's kind of, well, maybe there's an opportunity to. So that's a kind of collaborative approach. And then other times they just don't know the thing exists, and that's just always the way we've done it. So I feel like there can be this huge part where things fall down when all of a sudden it feels like the individual that's created this new process or a workaround has done it because they're trying to be a pain, when in reality they're just trying to get their job done, to be fair. And
I completely agree with that, Peter. I've seen that a lot. I've seen that a lot, and there is a potential mindset within IT to kind of denigrate people who are doing something off-piste, as it were. But you're absolutely right. The reason they're doing that is because the systems and processes we've given them don't allow them to do their job. Couple of good examples of one way and the other of what happened. So the first one was when we started with the referral management piece, the team who processed referrals were really eager to have a special queue for urgent oncology referrals. And the reason they wanted this was because in their paper-based process, because an urgent oncology referral really needs to be triaged that day, they had a separate pile for oncology and a separate pile for urgent oncology, and they would immediately get those across the campus to somebody else. So in their mind, that's what they needed digitally. Took us a couple of weeks to help them understand that in a digital process, those concepts are actually irrelevant, because as soon as you allocate a referral to be triaged by the oncology team, it's there. 200 milliseconds later, it's there. So the only thing that's urgent now is that the oncology doctors need to understand that they should probably check at least once a day and maybe twice a day to see if there's anything for them to triage. So it's a complete mind shift and a different process. On the other hand, we learned very quickly after we went live that some of our senior medical staff were getting frustrated because they were having to triage a referral that they had created to their own outpatient clinic in an inpatient setting 2 days earlier. So specialists would be asked to give a bedside consult, talk to a patient at a bedside and go, yes, actually, you should come and see me in my outpatient clinic, make a referral. 2 days later, it comes back in their queue, and it's like, why am I being asked to triage something? So then, and this again speaks to Simon's point about the flexibility of the system and the ability to have complete control in our in-house development team, which is different to the way some of the traditional systems of record operate. We just went and built a new process which allows a doctor to refer to their own unit and just bypass the triage, bypass everything. It just goes straight to the team who need to book that appointment in, because that's the efficient thing to do.
I actually had I had a really powerful kind of message from a colleague like years and years ago that was like, when you're trying to solve a process, look for the post-it notes. Don't ask people, can you send me the instruction manual? Yeah. Can you send me the protocol? It's take that, but then look for the post-it notes. And I think that kind of really goes to a lot of Alan's points and your points, Peter, of, people create these alternative systems either because they don't know or because there's real problems that the current systems are failing them. And I think that's been kind of a really exciting thing for us to be able to help health services with, when often, particularly in places like specialist clinics, it tends to be the pretty poor cousin compared to some of the other higher pressure. Well, high pressure isn't the right word, but I guess more front and center parts of the health service. And so, helping them work through what that looks like has been pretty cool, pretty exciting. One of the other things that we've been doing a lot in terms of that change and adoption process has been convening communities of practice with all of the user groups, so that, we've built that 80% system. But as you said, sometimes people, I guess they don't know what the system could do, or they don't know how they could actually change their implementation to make it easier for them. And so by bringing all of these users together, we're actually helping them help each other. And we're definitely seeing that kind of processes are getting refined locally based on what they've heard is being done at other health services.
I love the communities of practice concept, and like Simon, you'd be well familiar with, you're in healthcare, actually any industry really. Like you come to work, you've got a process, and the end of the last step in this process is I ship this thing out here, XYZ. And sometimes you may not think about, well, what happens to it on the other, or you've got an understanding of what happens about it on the other end, but how much of a difference it can make when you kind of get to see the bigger picture and you go, oh, well, I spend half an hour on this and you don't even use it anymore, or there's I'm sure people can think of hundreds of examples, but sometimes having that visibility of what happens beyond you, Simon, can be super valuable to yourself, but also to the whole process.
I think that's so important, especially in this time of change. So we've got some outdated care models that are very facility-centric, and we're increasingly moving to a virtual world of patient engagement and shared care and empowerment. And you need systems that are flexible enough to evolve with your evolving business or clinical climate. And that's why in a very static world, you can outsource that competence to maybe a vendor who creates a solution that's going to be static, and you run that process forever. But when you've got these evolutions, the people who know their business the best are the Austins of the world, the Vic Healths of the world. That competence needs to stay in-house because it's a bridge to where things are going to next. I was particularly interested to hear, Georgia, that you mentioned that artificial intelligence can creep into the process, and that absolutely makes sense. You've got a paper-based process, you evolve it to a digital process, and then you think about how do we optimize that digital process so we do even better than the paper-based format, and then what's the third horizon potential for where this could go. And when that system and that design is under your governance, then you're in the driving seat to be able to do that.
100%. And actually on that theme, Alan, tell me about some more innovation projects or things that's happening on the Austin Health side. I'll also get George's take on it too, but we'd love to hear anything else happening at the moment.
Well, we should talk about AI, but Simon, it's not going to creep into the system. We will, in spite of Microsoft's best efforts, we'll control it. But thank you for all the agents. We did a project over the last 12 months. We got ethics approval to look at several ways that potentially AI could process referrals. The first and most robust was that initial document classification. Can AI discern whether a document on its way in is a referral, a result, correspondence, or something else? And it can do it remarkably well. Sensitivity and specificity are both above 96%. It's extraordinarily good at being able to do that. However, there's a problem with that. It's not 100% right 100% of the time. And whilst it may be comparable to a human, I am reluctant to use AI to do that classification job, because as soon as it gets it wrong, I think there'll be a big pile on that, oh, AI is rubbish and we can't trust it. However, as we did that project, we started to kick off a whole other, again, research-based projects where just looking at the content of the referral for all sorts of different reasons, trying to work out the general health of the patient based on the description of what's in the referral, trying to understand the primary purpose of the referral, which could sound a bit trivial, but honestly, when you look at some 16-page referrals, that's quite helpful information. So again, a very powerful set of tools. There is no doubt about that. But because of the electronic referral management system, this isn't hypothetical research. We actually have a pathway to put this into production. And that's where we're at right now. We've actually got a meeting in a week's time to start to float this with the senior medical staff. And the beautiful thing about this is we're not asking AI to do anything. We're not asking it to make any decisions. All we're doing is asking it to summarize the content of a referral and provide that summary to a doctor. And they can act on it or not act on it. Hopefully we'll get some feedback from them through some buttons or text fields or whatever. But the opportunity here is in the things that might get missed, possibly the things that even the person sending in the referral had missed. So a person could be being referred in for condition A, but deep within that context of all of that information, there is condition B or an indication of something else that may need to be looked at. And I think it's opportunities like that where, again, the AI will flag this and just say, but this patient also has this condition potentially. And then the doctor can decide. They can have another look at it and go, actually, I don't agree, that's not a thing, or actually that is a thing and we should also get this patient seen by somebody else. So I think there's huge opportunity, and very excited to try and get this into production over the next few months and see where it goes. And then because ERMS is used at 3 health services, once we've got it working, if it works, then we can potentially deploy this to other people if they want to use it as well.
I love that supportive, intelligent augmentation type approach of that AI can add even at the introductory or small scale, but then that gives people a kind of view and an idea on how it can assist, and it's non-obtrusive.
A bit of confidence.
Yeah.
Because we're all in this world where it looks really compelling, but what can it actually do, and what are the risks? So I think we do need to all get a bit of practical, real-world confidence. And as you say, maybe it's a small first step, but we'll see what comes out afterwards.
Love that. Georgia, anything else that you're looking forward to continue to expand on or innovate on?
Oh, there's so much. And I think that's the wonderful thing about the Dynamics platform is that I don't think that there's anything that we've come up with or that health services have asked us for, like, oh, we absolutely could never do that. Sometimes it's a bit of resourcing and so we're constrained that way. But I think that's the really cool thing to me. I would say that there's probably 2 concepts that Alan and I have talked about a lot and are pretty taken by. So the first is this idea about federated innovation. So down the line, is there an opportunity that the CRM becomes not just something that only Austin is building, but we set, VicKey or whoever it is sets the framework for how we build things, but then we can bring in other services or other players to be able to roll out at scale new innovation to health services. So I think that's one that I think is quite an exciting evolution for us to look towards. And then the second is, I think we've seen a couple of times now the New South Wales Health kind of operational data store and what they can do and how, in actually what is quite a similar framework for us of lots of different systems, different PAS, different EMR, different radiology systems, how that's all been integrated into one data store, and then being able to, at scale, push out tools that help health services deliver better care and more efficient care. So I think those are the two sort of longer term things that I'm really excited about working towards. We are beholden to funding, as kind of all public services are. But yeah, that's certainly, I think, the future direction for us.
Being beholden to funding is the story of my life, Georgia. So I think anyone can resonate with it.
It's a fun treadmill to be on.
Can't spell funding without fun, though. And lastly, Simon, any other final thoughts you have on this one?
Just what Georgia mentioned about using your enterprise data. So I heard some incredible stats from the World Health Organization that hospitals around the world produce 50 petabytes of data a year, but 97% of it is never used again. That information has utility. So if you are collecting it, why not think about how you might be able to use that to drive real-time visibility through dashboarding and so forth, or even better cut applications on top of it that can expedite some of these orphan processes. I think anytime there's a Post-it note or an Excel spreadsheet, someone cared enough to do an MVP. It might not be digital, but that is an MVP. You can lean into it, and with these tools that are configurable and flexible, you can digitally automate that process. And then increasingly, I think we think about AI from outside the health system and look in and say, well, doctors and nurses diagnose and treat. That's what we should bring AI to bear. But from what Alan said, there's so many low-hanging opportunities around process that don't involve patient risk as well. So just being smart about how we lean in and make use of some of these new technologies. And the final point is the iterative process of it. Once upon a time, you used to buy a system and implement it, and then you have to train everyone because it wasn't intuitive. The concept now that you might be able to put in a system and then refine it iteratively over time, that's really powerful.
100%. And Simon, if we hear administrators or clinical coders refer to their Post-it notes as this is my MVP now, then we know who to blame for that. But 100% true. And if we can get more project teams, health systems, and even the tech community side to be thinking around the power of that co-design and collab around implementing, then that's a win for everyone. So super appreciative of everyone's time for this conversation today. All the details for Austin and Microsoft will be in the show notes of this episode. Georgia, Alan, Simon, thanks so much for your time.
Thanks, Peter. Thanks, everyone.
Thank you very much.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.